back together again this week. I'm Alan Winter, and with me I have my colleague Charles Zelnick. And we're going to talk today, continuing our series on AI in medicine. Charles?
Yeah, so we started, this is the third in the series what we've been doing. Remember, we started the first one with the title, Will Your Doctor Be a Robot? And we talked a lot about trust and how artificial intelligence and systems that help the doctor and help people in healthcare have to be based on trust. And part of that talk, that first talk, was about quality as well, and what makes quality from the patient's point of view. And we talked about that some more in the last session. Uh, the smartest person I know, my wife, what she would like to see when she goes to see the doctor. And this brings up the opportunity to talk today more about access, Alan.
Okay.
But we want to talk about, can AI and can other systems help me get the appointment I need? And the story I have about that is my wife and I moved to a new community, and she called to see a new doctor. She wanted to see a female physician, and she called up last October, and they said, "Oh, good news, we can see you in January of 2027." Which is 14, 15 months away. So we've got to skimp by without a primary care physician locally, and that brings up the whole question of what is access and why is there a crisis, that we'd want to talk about today. So why is it that you can't get an appointment to see your primary care physician, or can't even find a primary care physician? We only have capacity with the current number of physicians who are doing office practice, and this is all the primary care physicians who are in the office, including family physicians, internists, pediatricians. We only have a capacity for 180 million visits a year. So it's quite a bottleneck. And you can see in my diagram here, there's a huge river of demand, but only 16% of that demand gets seen in a physician appointment. And this is not a new thing. This has been going on for many years. And one of the things that's been a big part of it is that, one of the ways this is handled is a lot of people just don't get care. And so about 14, 15% of these appointments are ending up with care that's not seen right away, or when it's needed, or just people going without care. There's been rationing going on for years and years through the insurance system, where 9% of visits are delayed or not seen due to high copays or deductibles. This is a negative incentive to see your doctor. Or you can't get seen because prior authorization, that's about 7%. And then there's the whole chunk of people who are uninsured. That's gotten better since the expansion of Medicaid, but still somewhere between 5 and 7% of patients are uninsured, and this keeps them from being seen by a physician. So about a third or more of the demand goes to people just not being seen. Another third goes to people being seen by somebody else. So your doctor may not be a robot, but they might be a physician's assistant or a nurse practitioner or a pharmacist, or even just a nurse or a community health worker. And so we see 12% of visits going to mid-level clinicians, 10% in urgent care and retail clinics, and then a lot of self-care. 13% of people just care for themselves. They go to the pharmacy, they buy whatever they need for their upset stomach, and take medicine over the counter and hope that's going to work, or they treat themselves by getting information from the internet. And then what we want to talk about some today is, how much of this river of demand could actually be handled by using computerized or artificial intelligence or other types of expert systems. And this would include things like just using the computer for e-visits or telehealth visits, using the portal, the physician portals, to try to do care without having come into the office, and using AI triage and automation. That's a big topic now. I'm getting emails in my box that say, buy this computer program, this AI receptionist, and you can fire your receptionist and only get by with one person at the front office instead of two, and they'll take care of all your patients' needs. They'll schedule them for you. They'll refill their prescriptions, and we want to talk about, is that vaporware? Is that actually going to happen? I want to make the point that a lot of this problem with the access to care has been based on decisions made by our government over many years, over decades, and most of these things are not going to solve overnight. Most of them are structural problems, and even if we look at the topic we're going to look at today of how electronic systems can help us, currently AI triage is only about 1 to 3% of current care use in helping with meet this river of demand. Um, the projections are that at the best, putting all these systems into place, we might take care of 5 to 10% of the demand. So there's a lot of demand out there that's not going to be met, mainly just due to workforce issues, and we need to talk about how doctors and patients can help deal with this ecology that we currently have of the healthcare system.
And certainly, this stuff is real in the sense that this type of demand and lack of care exists every day. Why don't we have access? It's pretty easy, as you say. We we have insurance coverage gaps, and we can't do anything about that right now. That's going to have to be a governmental or a community based solution. Uh, there are language and cultural barriers to patients. I think uh, you and I both see people in the free clinic that can't speak English, and we really don't have any systems to be able to take care of them, as well as cultural issues that people are afraid of care. I mean, and that was a problem recently in my state with the measles epidemic. It existed in an Eastern European group of patients who were afraid of governmental um, uh, intervention, like as in shots, because of their history in Eastern Europe. So these things are real. And then, of course, you spoke last week about the geographic maldistribution
Mhm.
of healthcare. I mean, that's legendary. Would you agree that's our probably our biggest problem?
Workforce shortage, yeah, that's really the big problem is the conveyor that produces primary care doctors has not been keeping up with the demand, and as we talked in a couple previous weeks, the age group over 65 is just growing tremendously with baby boomers, and those of us who are baby boomer doctors are retiring. Um, so the younger generations of doctors, which have not gone as heavily into primary care as we did, uh, and there are lots of reasons for that, but there's just the shortage that we talked about. It's going to take quite a while, 10 to 20 years to fix.
And there's educational issues. I think the average medical student now has $200,000 in debt. Um, Underfunding of primary care, we've certainly seen that um, compared to other countries that invest way far more money in primary care, and the administrative burden that is the the amount of work that the doctor is expected to do, and finally, clinician burnout. So that's why we don't have access to care. And maybe we can only improve this 20%, but I think we can improve how a doctor works a lot more than that. What are we going to talk about? Well, let's think about Willie Sutton, the 1930s bank robber. When asked, why do you rob banks? He said, that's where the money is. So we're going to concentrate on where's the money in terms of technology for doctors. And I think we can start with with the with the idea that we can't do anything. We're not going to improve insurance coverage, so we can wipe that. There's no money there for us. Again, the language and cultural barriers and the geographic maldistribution are areas we can really work on. So let's talk about those in depth a little bit. And and the first thing to realize is that telehealth was illegal in 36 states until 2020. And I can really comment on this because I worked in with consultants to try to get telehealth accepted as for 20 years. And I've in fact testified before a number of state boards about the safety of telehealth, many times being thrown out of the board meetings because they didn't want to hear it. We were uh, the illegality of telehealth was real until we were able to prove in the state of Utah that it was actually for some illnesses, which I'll delineate in a bit, that don't need a physical exam. It was actually safer to use an e-visit than it was to actually see the doctor in the clinic. And this was really a apostasy to the medical profession. And I'll never forget in 2020 with the advent of the pandemic that I got an email from the state board that said that everything I had been talking about that they had complained was not legal. Suddenly it was legal at 10 o'clock on a Friday night. Suddenly all the laws went away, and it was all because of the pandemic. So things can change in terms of health. So telehealth usage actually went up a lot as a result of the pandemic, and you can see that the um, the numbers extended into the last few years. But look what happened. They started to pay in 2020. Then they stopped. They said they were going to stop payment in 2022. And look what happened. But there was a demand for the telehealth because everybody was using it. So then they said, okay, we're going to continue to pay for it. And you notice now it's gone back up a bit and has continued to go back up. So this issue about reimbursement, insurance, and payment is absolutely critical. And this slide demonstrates it dramatically. And why has it gone down? And the answer is because nobody wants to pay for it. Because if you think about it, if if you see somebody with a telehealth visit for a urinary tract infection and charge them $39, well, if they go to the office, they can get $100 fee plus a urinalysis, and the fee goes up to $150. So if if you start doing telehealth visits, you're going to lose money at your clinic. So until we rectify this idea that you get paid a different amount depending on how you take care of the patient, nothing's going to change. Would you agree, Chuck? Chuck?
Yeah, yeah. So, my stories about telehealth are basically two perspectives from a rural doctor's experience. I was doing opioid dependence treatment in my office, and um, when the pandemic came around and we couldn't bring people into the office to get their urine tests done or to do their visits, we started doing them by telehealth because these are people who just have to have their monthly visits so they can get their prescription or they get really really sick. And I'll just say as an aside that treating opioid dependence is probably one of the most satisfying things I did in my practice because you'd see patients get their life back and start parenting their kids and get a job, and it's just really a wonderful thing to do for these patients. Um, but then after the pandemic sort of tapered off and the patient said to me, can we keep doing telehealth? And I remember one woman in particular, she was on an island that was only about 5 miles away by boat. But for her to get to my office, she had to take a ferry and drive 50 miles around and cross the bridge onto my island to be seen, and then turn around and go back the same day. And it was just too much of a geographical barrier for her to keep doing that. So she could get on her phone and we could do her telehealth visit, and I would have her randomly. I would text her or say, today you need to go in and drop off a urine sample, so we could monitor that just and give great care. And actually, she was more regular about getting her visits in telehealth than she was coming into the office when it would snow or something, and she'd call in and say, "I can't get around today." The other thing we saw in our practice was a lot of our behavioral health was switched over to telehealth, and it stayed that way. And for patients in rural areas, particular, and for inner cities, mental health issues are are a huge need. They're a huge need everywhere, but being able to access them by telehealth is the difference between access and no access. So it's really important that we all advocate for continued payment and support of telehealth services because these are very efficient. They don't require as much office staff. They give the patients good care, and they're just generally a good thing all the way around for medicine, and they help us with the access bottleneck.
Exactly. And and then the other thing about telehealth is that there's a lot of different ways to think about it. And telehealth is really non-visit care, if you will. It means that you don't actually see the patient face to face, and uh, but we've been doing this for decades. The telephone is really a form of telehealth care. It's certainly a waste of time in many cases because it there's no documentation, and it's very difficult to keep up with what you did a lot of times. The other thing that happens is unstructured emails. They're hard to read. And we get these now with my chart messages to the doctor that's filling up the inbox. And these end up with time consuming email ping ponging and so forth. They are asynchronous, so you don't have to answer them to the end of the day, but they're really not a good solution any more than the telephone is. Um, a better way is actually either a real-time synchronous visit, as in if you don't need to, as I say, take the patient's clothes off, just see them on the video, and you can get a lot of information about them doing that. Or another way is a structured email, or it's called an e-visit, in which they can complete. It's formatted. It makes the medical record for you. It's an effective use of time. You can look at it anytime you wish, and it actually does solve a lot of these problems. So those two, the telemedicine video and the structured email or e-visit, is really where we need to look for increased efficiency. And we're going to look at why some particular illnesses lend themselves to that. I think you've been looking at this patient self scheduling, Charles.
So yeah, so let's talk about this a little bit. So besides using telehealth to reach out to patients, another way to deal with the big gap, the bottleneck in appointments availability, is to try to make sure that the people who need to be seen are seen in the right time frame, and people that could be treated by a lower level of care, such as a mid-level or a nurse or a physician's assistant or a pharmacist, that they're properly triaged to the right place. And so um, there was a lot of enthusiasm with web portals that went out that were required for all of us who had EMRs in our practices to put out a portal patients could self-schedule. But the uptake I found about that was that it was not very good. There were only 4 to 15% of appointments were self-scheduled, even though it was widespreadly available. And usually it was the younger, really internet savvy people who've grown up with the internet who were doing that. And my geriatric patients were not going to schedule on the internet. And part of that is just because if they try to get on the internet and they're given a couple appointments that may not fit their time, then it's hard for them to come around and say, well, that day's not going to work. How about another day? And by the time they're working through the web portal to get the appointment that they want, they could have done the job in 2 or 3 minutes on the phone talking to a real human being. I want to talk about, when we talk about digital scheduling, we got to compare to what is human scheduling like. And I have a couple stories about this. One is that from years ago, when I was a medical student in the 1970s, um, I did a rural medicine rotation. It was one of the experiences I had that made me go into rural family practice with an old doctor who'd been in the small community in southern Ohio for years and years. And his scheduling worked like this. He had a waiting room, a big waiting room. It was full of church pews. They were really uncomfortable, but it was okay because there was nobody in the waiting room. There'd maybe be one person in the waiting room. And the way that worked was his office did not take any appointments ahead of time. He had what is now, one of the hot things in scheduling, which was open access scheduling. You need to be seen that day, you're seen that day. And it worked like this. His nurse would open up the door at 8 o'clock every morning, and all the patients would be standing outside in a row, and they would come in and they would write their name down and tell June, the nurse, what was wrong with them. And June would look down the list and she'd see who was ahead of you and who was behind you. And she'd say, okay, you're got a stomach ache, come back at 10:30, the doctor will see you then. Well, she knew all these patients because she'd worked with this doctor and in this community for years and years, and she knew everybody because they were her friends and neighbors, and she knew the patients really well because they had continuity of care in the office. And we'd come back from the hospital rounds, and Dr. D, he would start seeing the patients, and 10:30 would come by, and that patient would not have waited more than 5 minutes. So that's the bar I think we got to hit. When I went into my own rural practice here in Maine about 18 years ago, the nurse that I picked up that was working with the doctor I replaced, she was in a similar situation. She'd grown up on the island, she knew all the patients, and she was able to not only schedule them appropriately, but she could also take care of a lot of triaging of the messages. Is this an important message? Is this something we need to be concerned about? Is this something that can wait till later? Is this patient need to be seen today? Do they need to be seen next week? Do they just need to refill their medication? Do they need to be, referred off to the specialist right away because they got chest pain or sent to the emergency room? She could do all that triage as well as just schedule the appointments. So those types of human systems are where we need to see AI or electronic systems. That's the bar to beat. And I know that a lot of primary care physicians don't have that kind of nurse working with them, but it certainly is the ideal. And I think we should try to get the best matching of the appointment demands and appointment needs to the limited system that we have, so that we're not having any waste when it comes to the physician's time and the patient's time in terms of getting seen when they need to be seen.
So these next generation of intelligent scheduling, what do you think they'll do?
I think it remains to be seen. I mean, I'm getting these ads in my inbox all the time saying, you should sign up for this software and you can fire one of your receptionists and it'll do just as well or better, and it'll speak Spanish and Portuguese and whatever your patients are speaking. But I don't find in the literature really any really good evaluations or studies that have tested this out. I think we have to really be careful about vaporware at this point. That there's a lot of promises being made, and whether it's actually going to work out, we remains to be seen. I would really like to visit or see some clinics, and maybe those of you listening to us or watching this, if you have experience with one of these new intelligent scheduling AI agents, email us or call us, or put some comments on the video, and I would love to hear some real life experience about this. I think it certainly has. It's a great dream. It's certainly probably better than a phone tree. Um, but I think scheduling and triage, scheduling is not so hard. Triage gets a little tricky because you don't want to send the chest pain patient to an appointment 2 weeks from now, and certainly giving advice like my nurse used to do, and then run it by me or say I want to give this advice when I call the patient back. That really we're going to talk about that next week. That's a real high bar.
Yeah, the advice and the triage are really where we may find the problem because we know that this has been looked at previously in terms of how should scheduling occur, how should you uh, uh, use your staff best to schedule patients, and certainly there's been an experiment in Sweden. They in 2010 they had a national policy to begin focusing on primary care, and in a couple of years they transitioned from fee for service to a model in which they paid each doctor a fee for each patient they cared for. That's called um, uh, pay for performance or capitation. And we're trying to do that today. You see a lot of talk about that in healthcare policy, and insurance companies and Medicare and Medicaid are trying to pay that. But You can't do both. You either have to do one or the other. Well, they did it in Sweden, and they just said on May 1st, everybody's going to change, and you're just going to have to deal with it. And that's probably the way to do it, not what we're doing of taking years to try to implement one while trying to do the other. But anyway, what happened was the suddenly before the patients had to pay a fee, and then suddenly in 2013 they could be seen for free. So that created a problem of a lot of patients coming in, and in fact there were twice as many people calling as they had appointments that were available. So in other words, every day the doctor maybe had 30 appointments. Well, 60 to 70 patients called. So what do you do about that? And the answer was they decided to use nurses. So they told they had their nurses screen all the patients that called up before they could get an appointment. You had to talk to the nurse, kind of like your Dr. D, Charles. But these nurses would have 2 minutes. That's the maximum they could do. They had to decide whether the patient needed to be seen or not. No, they didn't. They couldn't talk to them for 10 minutes. It was 2 minutes or less because they had patients waiting online. They had to answer 70 calls. So this was all in the morning, and they had just a very short period of time. So what was interesting is they studied this, and they found out when the nurse was doing this in 2 minutes that 18% of the patients, the nurse said, "Oh, you need to come in." But it turned out these patients really didn't have to come in. They could have been handled by other means, a recommendation, a prescription, some advice, or so forth. They could have waited until the next day or the day after that. So they didn't need to be seen. And 12% of the patients, they told, "Oh, just stay home." Well, those patients actually needed to be seen, and their condition could have or did deteriorate until they were seen. So the answer with the nurses screening the patients, and these are licensed nurses, was they were making a 30% error rate. And you say, well, how are we ever going to cope with the volume of patients demanding access if even nurses are making a 30% error rate? So I was involved in this, and it was actually interesting. What we did was we did a an interview before they talked to the patients using a structured interview of over line. In other words, you got online and answered some questions that were detailed about your complaint, and it was intelligent in that if you said you had abdominal pain, it would ask you how long did you have it, and where is it, and so forth. How bad is it, and all that sort of thing. But it was intelligent, so it adapted to how you answered. So then that result was given to the nurse before she talked to the patient. And this was critical. In 2 minutes, the nurse only got a limited amount of information, because think about how many questions can you ask in 2 minutes? Whereas by doing pre-screening with an intelligent interview, the nurse had a lot more information on which to make the decision. And the results were rather dramatic in that if she reviewed the patient interview and then talked to the patient, she only had 3% of the patients to come in that didn't need to be seen. And no patients who really needed to come in were told not to come in, which I thought was an interesting use of, information technology, and one that we could certainly adapt pretty quickly to what we see in healthcare. And I think that's a real benefit. I think it brings out an important functions. Why do we need to keep a human in the loop? And that little example of the nurses answers it. Well, as we close for today, the real money, as Willie Sutton would say, is in the workforce shortage. And I think we'll close by saying we're going to come back next week and talk about these last issues about the workforce, how we can change the administrative burden and improve clinician burnout with AI tools. So, Charles, any closing thoughts?
Just thank you very much. And like it says there, congressional action is needed. So in terms of workforce shortage, keep that high on your list and write your congressman.
Exactly. So, until next week,
Until
goodbye.
next week. Thank you. Bye bye.